Good evening, everyone. I am Dr. Puneet, and it is my pleasure to welcome you all to tonight's webinar on understanding cashless insurance, issues and solutions to ophthalmologists. This event is a collaborative effort presented by UP State Ophthalmic Society and the TPA Process Improvement Initiative Group of Uttar Pradesh. I thank our President, Dr. Vinod Rai sir, Dr. Malay Chaturvedi, President-elect, Dr. Shashank Kumar, Vice President, Dr. Mohita Sharma, Secretary UPSOS, and all the executives of UPSOS for their support and encouragement. My special thanks to Dr. Shashank Kumar, who took up this cause of member benefit and for his persuasion and inspiration in organizing this event. We are here today to learn and discuss about the increasingly relevant world of cashless insurance, a topic that is reshaping the landscape of healthcare, especially in ophthalmology. Our aim is to navigate through the challenges and uncover the practical solutions that can be applied to our daily practices. We are honored to have Dr. Major Harikrishnan Vannadil, a distinguished ophthalmologist and an authority on TPA and insurance issues, as our featured speaker today. Dr. Major Harikrishnan is an alumnus of AFMC Pune. He is Director and Chief Consultant of Iris Eye Care, Hyderabad, Director of Iris Mediworks, an independent consultant for health insurance processing in hospitals and related practice management domain. His expertise will undoubtedly provide us with invaluable insight. I have attended his workshops and lectures on insurance and other practice related issues and found them very practical and very useful. I am also joined by my co-worker, co-moderator, Dr. Ruchir Tiwari from Noida, and a panel of esteemed experts, Dr. Roop from Meerut, Dr. Sanjeev Hansraj from Lucknow, Dr. Shashank Kumar from Gorakhpur, Dr. Gaurav Mishra from Meerut, Dr. Sudhir Srivastava from Lucknow, and Dr. Ankit Agrawal from Allahabad. I also welcome once again Dr. Vinod Rai sir, our president, to join as panelist. Each one of them will bring a wealth of knowledge and experience to our discussion. I also extend our gratitude to Microlabs Private Limited for their generous support in making this webinar possible. And finally, to all our attendees for participation. Post your queries on chat. Moderators will ensure that the reply from the podium is given. We encourage you to interact and share your perspectives throughout this session. Thank you for joining us. Now I request our featured guest speaker, Dr. Harikrishnan Vannadil, to start his presentation and talk. Thank you, sir, and welcome.
Thank you for the very colorful introduction, sir. So, contrary to the normal presentations, here what I'll do is I'll share my screen in between when it is required. Okay, because I generally would like to talk to people directly so that people understand it as a concept rather than have a table to by heart. Just a minute, sir. So, so let's start with what is health insurance. Okay, one concept that you should understand that health insurance companies, just like any other business enterprise, they have their own business modalities, business ideas, and they are a company which is sitting to make profit. They are not doing charity. They are not, for the welfare. They are actually a business enterprise. So first thing, we should be very clear that they are a business enterprise. Additionally, another thing that we should be very carefully looking at is our hospitals are also business enterprises. Okay. Yes, we are doctors, but at some corner of our mind, it should be there that we are business enterprises. Now, for many years, it used to be like a patient used to come, used to pay, and they used to get the treatment. But nowadays, health insurance is becoming a big thing. Now, how does a health insurance work is, it works on the concept of indemnity. So there is a risk and there is a coverage for it. So when we buy a health insurance for our four-wheeler, we have a car, we have an insurance for that car. Now we buy the insurance, or it is mandatory by law to get the insurance for the car because there is a chance that the car will meet with an accident. It can create some damage to a third person or yourself or whoever, and at that time we should have a corpus of money to cover it. So health insurance also works in the same way. So just like the car insurance, health insurance, they sell the insurance to 100 people, and 100 people don't utilize insurance. Maybe out of that, 10 or 50 people use, so that the entire collected premium from all the people can be collectively used for the treatment of that 10-15 people. Now, this is the basic concept of insurance, which works in the case of fractures, which works in the case of heart attacks, it works in the case of appendicitis, because not everybody gets these diseases. Now, here we ophthalmologists, we are in a very different kind of a situation, saying that our majority of workload being cataract is an eventuality. It is not a risk. So heart attack is a risk, a fracture is a risk, an accident is a risk, appendicitis is a risk. But cataract, which is our main bread and butter, that is not a risk, which is an eventuality. Just by being a human being, we'll get a cataract. Okay. So the insurance companies knows this. So our business, our entire hospital, our practice model does not fit well in the insurance infrastructure. That's one thing you should understand. Initially, cataract was not covered, but as time went by and a lot of complaints, Supreme Court pleas and everything, cataract got included in the insurance coverage. Now coming to what does the insurance coverage mean to us is that why should we take a cashless insurance coverage? So a lot of people ask me, sir, why not go without insurance? So as the time is going, especially after COVID, a lot of people have started buying insurance. I think everybody would agree with me that in recent times, we have seen a very high number of patients coming with health insurance coverages. The reason that you should understand is COVID happened, people got scared, they bought health insurance, and now they are completing the 2-year or 3-year waiting time. So now everybody is taking out their insurance card for cataract surgeries. So that is why we are finding a sudden influx of insurance cases in the past few months. Around 6 months, 1 year, I think everybody would have seen that there is a huge number of insurance cases coming in. So this is the thing. Now, over a period of time, every individual is planning their finances, is planning their risk. They're mitigating the risk of sudden expenditure. So suddenly you tell somebody that you have a cataract, you need to operate. The patient might not be able to shell out 50,000 rupees for that. So because of that, what they're doing is they are buying a health insurance to cover for their treatments. Okay. Because of that, our patients are more and more being converted to people who are covered with health insurance. Now, when we have a good clientele of health insurance covered people, and at that time, if we say that no, we will not cover cashless, then we are very, very likely to lose our patients, because apart from the clinical decision making, apart from choosing the doctor and the hospital, finances play an important role. Now, there are patients who go to the best doctor, consult, they look at the cost for the treatment, and then they go to the government hospital. I think everybody would have had that experience where patients who are not able to pay, you would have lost. You would have lost patients who said that now in health insurance covered patients, what is going to happen is this kind of losses will not happen, because the patient is not worried about the expenses. So that is why the cashless is essential in today's world. Okay. So it might be, I can say bluntly that it would be foolish to say that we will not do cashless. But the only thing is we should understand what the cashless system entails. Okay. So anywhere, sir, anybody needs to ask a query, please kindly shoot, kindly interrupt, no problem at all. So I'll be happy to answer queries as we go, because it helps the discussion happen. So one thing that you should understand in cashless is an agreement between the hospital and the insurance company. It is not an agreement between the hospital and the patient. It is not an agreement between the patient and the insurance company. It is an agreement between the insurance company and the hospital. Now, what has the hospital actually agreed to is that I will treat your patient first, you can pay me later. This is the crux of cashless. So here there is an element of credit. So we are giving a credit period to the insurance company. Okay. So when we look at a credit period, it is just like any other business. So whenever go to the local kirana shop, every house would be having some local kirana shop where they will be like monthly rations they will buy, and at the end of the month you pay. Okay. So at the end of the month, when you pay, you are the paying person, right? So what you will do is you will check what all you have ordered for. You will say, "ये यार 1 किलो का दाल ये तो नहीं मैंने नहीं मंगाया था, check कर जरा." Then you will check. So cross-checking happens when it's a credit billing, because the person who is taking the items are different, person who is giving the items are different, and the person who is making the payment is different. So here cross-checking will happen. So what should we do as hospitals is make our systems so effective that we can defeat and overcome these cross-checkings and take it out of a headache. Okay. So in short, our document procedures and our bills and our systems should be such that it should be वहां पे जो the lowest IQ person should be able to understand and process your documents. Okay. Now, as doctors, we are very much fond of writing cortical spokes, cortical opacity, thick plate posteriorly, posterior polar, right? Now, the person sitting as a claim handler in an insurance company, he might be a graduate, but okay, let's, for our convenience, let's degrade him, demote him. He might be a 10th standard pass. So what does he know? He knows cataract. So one incident which happened with one of the multi-specialty I speak with is, which I recall to a lot of people, is one patient was admitted and they had sent a pre-order. Pre-order didn't come. The insurance company asked a question for medical MLC. Why? The diagnosis was RTA. RTA was the diagnosis, and insurance company replied, kindly forward the medical MLC document. Hospital said there is no MLC initiated because it is irrelevant. Same query again, same reply again. Same query again, same reply again. You know the background story. It was not, the RTA was renal tubular acidosis and not road traffic accident. Okay. So this is how we make stupid mistakes. Malab, it is not that stupid from our side. See, the doctor is very correct in mentioning RTA, renal tubular acidosis is meant. But had he used the entire diagnosis and an ICD coding, this incident wouldn't have happened. Correct. So what I again and again tell people in my workshops and training program is that we should idiot proof our bills and documents. Okay. So one thing you should understand is how the claim processing happens. So there is something called TAT, that is turnaround time. Every insurance company is a company who is looking to get more clients. It's a business. So how the business responds is how they get clients. Now they have a turnaround time that they should be able to process the documents faster. So our job is to make the process, help them make the processing faster so that we get the approvals faster, we get the payments faster. Okay. So here, starting with, in order to make that faster, what we essentially need to do is that understand the systems, improve our systems. Okay. Now I'm coming to the entire workflow for health insurance. Okay. In cashless. Okay. Now, the idea we had about cashless is that, just a minute. Idea we had about cashless is that whatever the insurance will pay, and that is not the case. First of all, insurance company likes predictability. Predictability in the sense, how many of their clients will seek this treatment, and if they seek this treatment, how much claim outgo they will have, right? They should be able to plan their finances. They shouldn't be hit surprisingly with some huge bills so that they are not bankrupt. So in order to have that predictability is what cashless system and provides. So what the process for starting cashless is something called as a hospital empanelment for cashless. Okay. Now, when you look at the empanelment process, what does it entail? The insurance company will first verify whether this hospital is genuine or not, whether this hospital exists or not. For that, what they do is they ask you for the hospital registration documents and other pollution control board and all those legal documents, that whether you are a legally correct hospital to run. Second thing they will ask is whether you are financially correct, because hospital name is Drishti Netralaya, owner's name is Dr. Gopal, account name is Dr. Vaibhav. This kind of a mix-up shouldn't happen. So that is also another thing. See, they look at the healthcare registration rules that it's legal to run the hospital, and then they look at the financial aspect, that whether that is correct. So that is why they ask for your PAN card. You might be asked to get an NEFT form signed by the bank, your cancel check, your incorporation certificate if it is a private limited company, some LLP or a single proprietorship. So those connected documents. So now the insurance company has verified that you are a genuine hospital, you are financially correct. Another thing they will see is, do they actually need to have one more entry in their database? See, any IT infrastructure, in order to empanel a hospital, there are staff involved, there is time involved, there is effort involved. So they will see whether it is worthwhile. So how do they judge whether it is worthwhile? Is that if it's a new hospital, they judge by the doctor and the people who have started the hospital, whether they think that today, tomorrow, they will have a good amount of footfall. Next thing they look at is if they have received any reimbursement claims from your hospital. So if you have sent any reimbursement claim from your hospital, it is very, very likely that insurance company will be interested in empaneling you. Why? We will come to that. So now what this insurance company is going to do is they are going to come to you, and let's not talk about the packages now. Let's first look at, just a normal billing. So just like, when we go to a restaurant and you want to cater for 50 people for food there, normally they would be having a buffet of 1,000 rupees per plate. But when you have 50 people, you will go and tell them, boss, 1,000 nahi dunga, 900 mein kaam baat kar le. Right? This kind of bargaining happens everywhere. It happens in any business. So here, what insurance company is going to do is they are going to come to you and tell them that we are going to extend our cashless network to you, and you will be able to do cashless services to your patient. That will increase your footfall. They know that. It's a fact that when you do cashless, your footfall increases. So what is the discount that you're able to give it to us? Okay. Now, in surgeon fee, OT charges, you will say that 10-15% discount, whatever negotiated. Now coming to the package rate. Now, there are standardized treatments for standardized diseases like cataract, appendicectomy, VR surgery, whichever. There are few diseases for which the procedure is standardized and more or less the outcome is predictable. So for those cases, they enter into something called as a package rate. So what is the benefit of package rate is, from hospital side, we don't need to give a breakup. We don't need to give an implant invoice. We don't need to give a pharmacy breakup. We don't need to give the entire description, and we don't need to put the headache. From the insurance company side, the ease is they have a predictability of the amount they have to pay. So they have entered into a package rate. If the patients, some extra visco, some less visco, somebody uses, in some cases, you have to have extra time. Some cases are over fast, some are hard cataract. You so these kind of small differences, adjustment. So we will not every time cherry pick the differences. So it will not be like one time 25,000, next time 26,000, next time 23,000, next time 30,000. So insurance company loses the predictability. Every bill they are forced to cross check. Now, when it is a package rate, if you enter into a package rate as cataract, MICS, whatever for 25,000. So you are not required to send a bill with the surgeon fee, anesthesia charges or anything. You just need to type out a bill which says item number 1, package name so and so. Now, let's not create our own packages. So understand something, that when we get empaneled with an insurance company for cashless, we might be having a big tariff list on our hospital wall. The moment we sign an agreement, that tariff list disappears for the clients of that insurance. This is one fact that we should remember. अगर हमने एक इंश्योरेंस कंपनी के साथ साइन कर दिया कि 25,000 में हम इन मोनोफोकल एस्फेरिक लेंस डालेंगे, आपके चार्ट में उसके लिए 30,000 हो या 20,000 हो या 15,000 हो, फर्क नहीं पड़ता. आप वो 25,000 जो भी आपने साइन किया है वही आपको फॉलो करना है. So this is one biggest plus. So here it is not the healthcare angle, here it is not the patient angle, it is basically how much you are upholding the agreement that you have signed. So you sign an agreement that I'm going to charge this much for your clients, that is what you have to charge. If you're charging that, there is no problem. Now, in our case, what happens is there are upgrades, there are patients who want higher implant options. I'll come to those. So that is a very common thing. Now, one more thing that you need to understand is insurance company handles. See, you might feel that I'm supporting the insurance company to a large extent, but that is just so that we understand the process. So the insurance company not only handles ophthalmology, their systems handle all the specialties, and there are many other specialties which has got volumes nearly equal to us. So their system should be catered to all of them. So what is happening is there's in cashless, there is something called initial approval and final approval. Now, initial approval and final approval, I normally explain, I'll try to explain it in a simpler way. So a kid goes to his dad and says that, Daddy, I want to buy one pencil, one sketch pen, and one geometry box and chart paper. I want some money. So what the daddy does is the father gives him 100 rupees and he goes to the shop, buys the stuff. So the daddy giving a blanketly 100 rupees to him is the initial approval. Okay. When that father gives him the 100 rupees as a blanket amount is the initial approval. Now he buys everything, comes back. Okay. He comes back, father asks him, ye kitne ka, ye kitne ka, ye kitne ka, ye kitne ka. Total hua 80 rupees. Total hua 80 rupees. So then the daddy, what he does is the father, he takes that 100 do diya tha, that becomes 80, he takes 20 rupees back. Right? That is our final approval. Okay. So the thing about initial approval and final approval, yes, I understand everybody asks that cataract में क्यों चाहिए एक ही बार में approval क्यों नहीं देते, but initial approval and final approval is going to stay. There is no doubt in that initial approval and final approval process is going to stay. So one of the mistakes that a lot of people do is that when we get an initial approval, we don't send for final approval. Even if you get a full amount approved in the initial approval, we have to send for a final approval. The reason being, the insurance company is binding on the final approval and not on the initial approval. Okay. So this is initial approval, final approval. Now coming to the documentation part. So initially we will send a pre-auth. So the patient comes to you. Initially there's a pre-auth, there is there's initial approval, then there is a bill and an approximate bill and discharge summary. And then there is a final approval. And after the final approval is the final bill and discharge summary. Okay, this sequence we should not miss. So the sequence is basically the patient walks in, you fill a pre-auth, you send the pre-auth, initial approval. After the initial approval, you undertake the treatment. Then we give an approximate bill and the discharge document to the insurance company. And once we get a final approval, that final approval ki hisab se we are supposed to amend our bills and then discharge the patient. So this workflow is very important to know, because a lot of places, a lot of hospitals which I handle in terms of queries, what I see is they have always discharged the patient on the initial approval itself without asking for the final approval. Okay. So this is the in a nutshell how the entire process works. Okay. Now recently one process has come called cashless everywhere. Cashless everywhere and this empanelment for cashless, the main cashless and the cashless everywhere are two similar but distinct systems. Okay, are similar but distinct systems. So in cashless everywhere there is no relationship with the hospital already, but in cashless empanelment there is a network hospital empanelment, there's a relation already established. So cashless everywhere, we had a webinar yesterday in which Mr. Anuj Jindal has described in detail. I'll touch upon that if somebody has got a query, but we will stick to the cashless empanelment part now. Okay. Now, as far as the billing systems are concerned, that is one thing which I would like to touch upon. So, so as of now, I think everybody has understood in concept how the cashless works. Okay. Now, in this, few things I would like to touch upon. In addition to that, is that there is something called Rohini. Okay, Rohini is Registry of Hospitals and Network of Insurance. Now, Rohini is a unique identifier of hospitals. As far as hospitals are concerned, we can only see the Rohini ID. We log in, we can only see our hospital details, and that's it. But when the insurer logins to Rohini, the data that sees much more in the sense they'll be able to see which all insurance companies you or hospitals empaneled with, even the rates, even your entire insurance claim data, they'll be able to see. So Rohini is a huge unifier in this thing. So that is there. Now, second, coming to what everybody is saying about insurance ombudsman. I have seen a lot of doctors say that, "नहीं, ombudsman complain कर देंगे," but understand, insurance ombudsman is for the insured and not for the hospital. If you look at even if you go to insurance ombudsman to file a complaint or anything, so what happens is the insurer will ask to get the complaint through the insured. So your patient has to file a complaint, not the hospital. So understand, as far as the insurance ombudsman is concerned, we are on the insurance company's team. We are not in the patient's team because they are looking at financially. Okay. So insurance ombudsman हमारे लिए नहीं है. हमारे लिए ऐसा कोई भी grievance redressal का system insurance company से आगे नहीं है. Our final grievance redressal ends at the insurance. Okay. So is one thing. Another thing that you should understand is GIC. GIC has been news recently for cashless everywhere. GIC is another entity that controls. It's a reinsurance company. We don't need to go into it. But GIC is also an entity with which works on the policy decisions of insurance companies. Now, so next word that we should understand is GIPSA. Okay, GIPSA का बहुत हमारे आगे हुआ है कि GIPSA का rate. GIPSA is nothing but a collective bargaining. So, how many of you would be part of the Ophthal buying group? Anybody part of Ophthal buying group? Ruchir sir. Okay. Supuneet sir. So you understand how it works. Basically, we take orders from 10 people, go to the vendor and bargain for a better price. So here what is happening is in GIPSA, there are 4 insurance companies, which as of now hold, if you combinedly see, they hold majority of the health insurance market. So these 4 companies have come together, formed something called as GIPSA, and they do the empanelment process centrally so that, see, I told you earlier about the discount. More the volume, higher the discount they can ask. So when, if Dr. Puneet's hospital is there and the GIPSA committee says that, no, I'll not give you empanelment, means it is likely that he will lose a lot of his patients. There might be a loss of business. That gives him a lot of bargaining power in the market. Okay. So GIPSA is basically nothing but a collective empanelment process. So a lot of people ask me, sir, GIPSA का rate कितना? GIPSA, sir, GIPSA का कोई rate नहीं है. They are a team of people who are going to come and bargain. Whatever you can bargain, you can bargain. You should be able to justify the bargain. Now, that is GIPSA. Now, what they do is these 4 companies cannot come together and do the same for every town, every city, every village. So what they've done is they started with Delhi, then Bombay, Chennai, Hyderabad, and now they are extending the process to all other tier 2 cities also. So over a period of time, you will find that GIPSA will be applicable to a lot of cities. Puneet sir, UP में किधर GIPSA है? आप any town which is sir, unmute sir.
Ghaziabad में we have GIPSA. Lucknow, I think, has GIPSA. Meerut also, I think, has.
So these are the new cities which are added actually, Meerut and all. Ghaziabad comes under NCR.
Yes.
So GIPSA, what they had done is they had distributed the country into 4 parts because there are 4 insurance companies. South is by United, West is by New India, North is by Oriental, and East is by National Insurance. So these people, whatever has to be done, these individual companies will do, and rest everybody will follow. So that is GIPSA. So that is now one interesting part about GIPSA that you should understand is if a patient comes to you with a card of New India Assurance and MBBS TPA, the tariff that you agreed with the GIPSA will be applied. Whereas if it is ICICI Lombard with MBBS TPA, then the tariff of MBBS will apply. So in case of ये तुरुप के चीट की तरह है सर कि मतलब if the GIPSA is there on the card, GIPSA will prevail. After GIPSA comes the TPA. After TPA comes the private insurers. If you are looking at the seniority of rates, so if you are empaneled with the TPA as well as the insurance companies and GIPSA, then if a patient comes to you with the card, if there is a PSU insurance company, your GIPSA tariffs will apply. If PSU insurance company is not there, go to the TPA's rate list. If the TPA is not there, then the insurance rate list. Okay, sir. Sir, I think somebody put a chat that there are a lot of questions to answer. So would you like to go into discussion mode, sir?
Puneet sir, you're on mute.
As you suggest, I think if you have, I mean, Vito, if you have some more to talk, then I think we can finish the talk and then take up the questions in the end.
Sir,
Yes, that is better.
we can
complete it first.
So basically, just give me a second, sir.
No, like somebody asked that although it is a package rate and you are not required to give the IOL bill and all, but still the companies insist that we need it. That is one point. Second point is that
Sir,
they ask for discount, but then it is their rates and discount also. Their rates which are already low, and on top of that discount. So we are left with no option. It is mandatory. Both the things are mandatory. So if we want it, we can take it or we leave it. So these are the two big. Mainly is the second one.
Sir, now coming to the first part. Okay. If a patient is being billed on a package rate, we don't need to give the IOL invoice. They cannot ask for an IOL invoice. When do they ask for an IOL invoice? Is in spite of having a package rate, if we send a breakup bill, then they will ask for an IOL invoice. So if you have a package rate for a monofocal lens for 25,000 and you write it as a single bill as 25,000, they are not going to ask for the invoice of the IOL because it's a composite supply. But the moment you upgrade the implant, you change the implant, you are not sticking to the package rate, you give a breakup bill, that is the time when they are going to ask for an IOL invoice. So, Sanjeev sir, in case any insurance company asks you for an IOL invoice after sending a package rate, I'll tell you the standard reply that you should give.
Okay.
IOL invoice cannot be provided being a package case.
Okay.
In case IOL invoice is required, request permission to convert the case to open billing.
I see.
Understood?
Right. Yes. In the past, they have even asked for the purchase cost of the lens.
नहीं परचेज कॉस्ट से सर उन्होंने जो एक बार पैकेज कर दिया तो परचेज कॉस्ट का आपको उनको फर्क नहीं पड़ता
वो तो बट है बट दिस इज व्हाट इज एक्सपीरियंस
ऐसे वाले अगर क्वेरी आएगा आप यू कैन कॉन्टैक्ट अस ओके सर सो we'll intervene, don't worry sir. ऐसे अगर कुछ होगा तो we have a robust system where we know the होता ही है सर बहुत बार जो क्लेम हैंडल करने वाले को खुद नहीं आइडिया होता है
हाँ हो सकता है
so that is a very common thing so
one has to get into correspondence with them because then they have to be made to understand, so it takes so much of your manpower and
no,
time.
sir, it's all about creating that one with the exact wording that if you use, no sir, it doesn't this thing. It doesn't bite. So this thing. I had a sir. What was the next question, sir?
Regarding the discount that they are asking for.
Hmm.
So firstly, they are giving their own rates. You know, first they ask for your rate list. You send the rate list. Then they say, no, this is not. We are not going to give you this. This is what our rate list is. You please agree. This is the rate you have to work upon. Okay, you
Sir,
signed that. You signed that MOU, and then
Hmm.
immediately you will not get this other. Recently, you know, they have now this. After some time, they will send you a letter saying that this is you haven't offered any discount, and please offer this much discount. Now, recently, I got a mail from one TPA. They said it is mandatory to offer 15% discount. If you do not offer discount, it is very much likely that insurance company will disempanel you.
Okay. Now,
So it is their rates and discount as per their demand. So what are we? What choice do we have?
sir, so okay. Now, if you look at the entire discount letter that you issue, okay. So if you look at the entire discount letter that you issue, it will have something called as discount applicable except excluding packages. This is standard wording. You can sign a discount letter. Say, if an insurance company asks me for a discount in my tariff for 20%, 30% also, I can proudly give it. I'll tell you the reason, because I will give it with the clause saying excluding packages. Okay. Uske baad, pura ka pura, you will bill in packages only. I bill in packages only. So the moment I bill in packages, none of the discounts apply. Okay, sir. Now, in this, I have encountered similar cases where hospitals are told that they have discount has been deducted. But most of the cases, we have seen is the hospital has not billed according to a tariff list. If the tariff mentions something, we mention something else, there's a confusion. Understand what happens in the insurance company claim processing center is there is a computer on which your bills are there. The claim handler will have another small window in which your tariff rate is there. He will just compare this and this. So that's why I said your tariff, your bill the wording should be exactly as what is mentioned in your tariff agreement. Okay. So that should not change. If your tariff agreement has got a spelling mistake, please copy and paste that spelling mistake also. Okay, sir. So that is how you defeat this part.
Okay.
And one more thing, sir, insurance company cannot force you to get empaneled for cashless. Now, one of the interesting part about bargaining is, okay, now that we have opened up the point of tariff fixation, let me touch upon that. How does an insurance company get the cost of a surgery? Now, it doesn't matter whether you use an Alcon machine or Zeiss microscope, or you have Centurion or Zepto or Femto, it doesn't matter. Your hospital infrastructure is not of concern. What is of concern is what is the going average rate for that particular product in your market. When I say market, at your town, your locality. If in your town and locality, if there is some other hospital which is onboarded with a rate of 15,000, then you are very, very unlikely to get a rate of 20,000. Why? Because जहां सस्ता है वहां से वो खरीदते हैं. उनको जो product उनको चाहिए, what is the product? It is the healthcare service for the patient, which they are getting at a cheaper rate at another hospital. So basically, unless and until all the hospitals come together and increase the general rate of the area, you will not. It's very difficult to bargain with insurance companies. Second thing is, if you have good number of cases which are going on reimbursement, then you have a very good bargaining criteria. कि आप reimbursement भेजोगे, उनको पता है, तो उस पे आप bargaining बहुत कर सकते हैं. ठीक है. So these are the things where you can bargain, sir. Now, another thing is, if you want to get a good rate, you should have the willingness to walk off. Walk off in the sense, एक बार बोलो कि भाई रहने दो. Say no. Say no and do some reimbursement, they will come back. I had a similar personal experience also with care. So this is the thing for tariff fixation, sir. Sir, anything else, sir? I'll just give me a second. Okay. So I think everybody knows how a pre-auth form is to be filled and what are the particulars. Okay, I'll take you through that once. So okay, Zoom and share screen. So basically here you can see one pre-auth form. Okay, this is a standard pre-auth form that we fill. So in this case, one of the biggest difference which you will find compared to many of the hospitals is how the pre-auth form is typed and entered. It is not handwritten. Why? The same reason that I told you, the claim processing person sitting in the insurance company may be 10th standard pass. So you should be able to, that particular person should be able to understand each and every part of it very clearly so that he can process your cases faster. Okay. Now, in this part, I don't think there is any doubt. I'll come to the next part. Now, here what you see is that with the diagnosis, the ICD code is mentioned. So even if in case of a doubt, in case of any ambiguity, in case of, for example, our VR surgeons who are very proud to mention, RRD with HST with traction bands. So apart from ophthalmologists, I don't think most of the people will pick that kind of diagnosis or treatment. Like we write ILM peeling, SOI and SOR. So instead of that, kindly use very simple words and use ICD coding. And here, if you see the entire wordings is, it's mentioned as per the tariff agreement in my case. In this particular insurance company, my tariff was mentioned like that. Now, the tariff, see, if you look at this part, so my tariff with GIPSA is 21,000 plus IOL cost. So here, if you see, there is the entire tariff rate as per the GIPSA is filled just like it is in my tariff document. I have not changed anything. GIPSA, PPN, OPH 1B, cataract excluding lens, MICS with unifocal lens. Because when that claim handler looks at this pre-auth form, even my bill will be same wordings. When that claim handler looks at your bill or the pre-auth form, he should not have an ambiguity कि भाई ये कौन सा package apply कर रहा है. Now he is under pressure of giving a response to you. He's an employee. He has got a timeline. So instead of looking here and there, in this, it's very easy for him. Okay. Now, one more part which is on the left, you will see is that it's an all-inclusive package, 21,000 plus cost of implant, 24,000. This is my package. If your IOL cost is included, kindly put it in the column N. And if you are going for a breakup bill, if we are going for a non-listed case, that is open globe injury or any other case which is not there in your tariff list, how much are possible, try to fit things in your tariff list. If a patient has come, try to fit him in your package rate. Don't try to open bill. If you open bill, that is going to have a lot of consequences because there is a lot of scrutiny of open bills. Now, in the left side, you already saw the costing. Now coming to the right side. Now, past history of chronic illness, we see it's very simple. The patient has to be made aware that it is your insurance, your past history, you are supposed to declare. We will mention, you please be truthful and mention it. Okay. Otherwise, if the patient has not told you, you also don't know, no issues. But sometimes it's very good practice that you mention it. Now, this is a standard pre-auth form that we fill and send. So in this case, now once the pre-auth form goes, comes the initial approval. Now, initial approval, what you need to see is that here in this initial approval, they have given me the initial approval only for 21,000. Just a minute. Yes. You can see that the initial approval is only for 21,000 and rest will be determined on the receipt of final bill. Now, why is it so? Is that whenever our implant is not in the package, or we are upgrading the implant to another implant, we are supposed to provide an invoice for the implant. Okay. Now, the moment we have to provide an invoice for the implant, the insurance company is in a doubt whether the implant invoice will come or not, because that is most of the places people are sending performer invoices, MRP letter. So these are not actually legally acceptable documents. The actual acceptable document being an tax invoice. So this is the initial approval. Now, in the final approval only, they will be giving the full amount, whatever copay, deduction, whatever according to sublimit. Now, in this case, what do you do? I can tell you in this case, what do we do? I do in my hospital is that insurance company has approved 21,000. 24,000 is balance. So that amount I normally collect it from the patient as a deposit. Okay. If there is a shortage of the approval. So you are actually allowed to do that because the approval is not complete. Now, if you look at the the terms and conditions of your MOU that you signed, that also mentions that any shortfall in approval, the hospital is free to take amount from the patient. So here there is a shortfall of approval. We can take the balance amount as deposit. Now, we will face a lot of patients who say कि भाई क्यों दूं? मेरा insurance है, मैं क्यों पैसा देना? So in that, you are supposed to explain to the patient that, sir, this is your insurance. They gave this much only approval, not my headache. I had sent the full amount. Okay. Now, if you don't want to pay deposit, please talk to the customer care or your HR department, whoever is handling your insurance, and they will take it from there. And accordingly, we can look at it. But as far as the approval has not come, the patient is going to pay. That is very simple. So this is the initial approval. Now, after the initial approval, we operate the patient. After operating the patient, what do we do? So just let me share the screen. So after the initial approval, what we do is we operate the patient. When we operate a patient, we are supposed to prepare a bill. Now, and a discharge document. Now, I don't think I need to talk to you on discharge document. We are doctors, we have been running hospitals, we know how to make a discharge document. But in the discharge document also, please mention MICS. There are many times when bill is for MICS and the discharge mentioned FACO, you are going to get an observation there. So you are supposed to put the discharge document at the approximate bill. What do I mean by approximate bill? Approximate bill is a bill which says so-and-so surgery, total amount itna, receipt from patient 0. Even if you have collected the deposit, because deposit is separate. Deposit is a escrow account. It's a side mein rakha hua paisa. Patient say collected, you on this bill you have not collected money. So collected from patient 0 and total due from insurance company, put the total amount again. So in my case, in the case which I told you, where I had got initial approval 21,000 and the total bill was supposed to be 45, I would have done the same thing. That the approximate bill will look like the surgery cost, implant cost total 45,000, received from patient 0, due from insurance company is 45,000 again. I send that approximate bill with the discharge document to the insurance company for final approval. Now comes the final approval, which says exactly how much of amount they are going to pay, how much of amount co-pay, how much of limit, whatever. So insurance company finally says, disease sublimit 40,000, insurance approved amount 40, patient payable 5. Now I got the final approval. I have the discharge document already ready. I'm supposed to make the final bill. So how does the final bill look? Is that 45,000, received from patient 5,000, due from insurance 40,000. See, understand, it's a credit bill. It's a credit business. We have not received the patient insurance's money. So it is always receivable from the insurance company, 40,000. So that is the bill which you are going to send as the claim. Okay. So the bill that you send for final approval and the bill that you send for claim is different. Okay, so that is what you send as a claim, as a final thing. So single line package. So if you, for example, if you are working with Star Health Insurance or Care, you will realize that most of your packages are single line packages where there is IOL is included in it. It's not an IOL excluded package. So in that case, what you need to do is you don't need to send an IOL invoice. You just need to provide the claim documents that you send is very simple. You have to just send the pre-auth form, the biometric report, patient's ID cards, the insurance card, Aadhaar card, KYC document, along with your discharge document and the final bill is for the claim. So this, if you follow this one process, you are going to lose money in this. You will not have embarrassments. You will not have surprises. Okay. Now, final approval is an authority. So because there is no change in the bill, now I have sent a bill for final approval. That is the same bill content which I am going to, and I got a final approval. According to the final approval only, I am making the final claim. So because of that, the final approval is an authority for payment. If only criteria where the settlement of a claim is different from the final approval is where there is a violation of terms and conditions of the agreement between you and the hospital. You will never find a final approval and settlement mismatch saying sublimit exhausted. See, as I told you, there's an agreement between you and the hospital, the insurance company and the insurance. There's an agreement between you and your hospital and the insurance company. There's an agreement between the insurance company and the patient. Whatever the terms and conditions of the insurance company and the patient is finished the moment a final approval is given. The final approval, once it is given, according to the terms and conditions of the agreement between you and the insurance company is how it is settlement. So unless and until you have not violated anywhere in that. For example, we sent an initial approval, the same case. In the same case, the approximate bill stated 45,000 due from the hospital, from the insurance company. And the final approval came as 40 plus 5. 40,000 insurance will pay, 5,000 patient will pay. But what I did is I charged them for something else also and took around 10,000 from the patient. And I increased the bill to 55. Sorry, 50. Now here there is a violation of agreement. Okay. If here there is a violation of agreement because you had agreed that you will treat the patient at a certain tariff, you have overcharged the patient, and hence it will be a violation of the agreement. Here the final approval and the settlement can mismatch. Okay. Now, another place I'll tell you where it mismatches. Final approval and the settlement. LASIK surgery. Okay. If a hospital, what it is, the prescription, the AR, everything says minus 7.5, minus 7.5, minus 7.5. You sent an pre-authorization. The initial approval came. You operated the patient and you got the final approval only. Final approval also. After you get the final approval with the claim, there is a document which you are supposed to send, which is called as ablation report. Now, ablation report is the report that comes from the examiner. If the examiner machine says that I ablated only for -6, that time, in spite of having a final approval, your settlement will be stuck. So here, the patient was given an overcorrection of -7.5 the initial, but when the actual final ablation date was for -6. So here, this is a justified case for settlement mismatch. Okay. Now, sometimes people send open billing. Okay. Now, understand the claim handler. Let's go back to the quintessential claim handler that we keep on talking about. हमने एक पैकेज रेट पे पेशेंट को बिल किया, इनिशियल अप्रूवल भेजा, सब कुछ किया, उसके बाद अगर हमने उसको उठा के ट्राइफोकल डाल के ब्रेकअप बिल भेज दिया, then the claim handler will get confused. He will see that initial approval is for package final approval is of breakup. So he will start deducting discounts because he has been instructed that the moment you see surgeon fee, OT charges, room rent as a breakup, please apply the discount. So there the discount will be applied, your final approval and settlement will not match. Okay, so these are certain situations. Now, there's a very common thing which is happening with one particular two particular insurance, one insurance company and one TPA. I don't want to name them because the video, there are a lot of people watching. One is a private insurer and one is a popular TPA based in Hyderabad. These two TPAs, this insurance company and TPA has a habit of document not received, claim kept on hold. And once you cross that mandatory period of 6 months, they will put the claim in the dustbin. Okay, then it is very difficult to open. So in such cases, remember one thing that comes to your savior as speed post. I hope everybody is aware that the speed post parcha of India Post is auditable under law. Your Blue Dart and DTDC doesn't count that it has been delivered, but speed post is counted as an evidence of delivery. So if you want to pursue those kind of cases, speed post always. And one thing I want to tell you here is that I have a scanned set of documents of each and every claim I sent. Now, many of you would be working on the old time scanners where you lift the Dakkan, place the document, press scan, lift the Dakkan, place the document, press scan. I think a lot of people would be doing it, right? So one thing which I bought from day one of my hospital is something called as an ADF. ADF is a huge scanner in which there is a tray on top. You put 30-40 pages on top, press start button, it will automatically scan. And it will automatically scan and save it in my Google Drive. So I have all my, before sending any document out, hard copy, before sending the document out of my hospital, all my documents are scanned so that if I have to contest later, I have a copy of it. So these are the actions you take on final approval. Now, in my short experience of handling a lot of hospital claims and going through the documents, I find that hospitals put a lot of unnecessary documents. We are a daycare center. We just need to put documents which are relevant to your claim. Okay. When you say okay. When you say claim relevant documents, what are claim relevant documents? Let me tell, these are the things that you see on the screen are the claim. Yeah. So this is the claim set, what we call as claim set. So now claim form part B is required only for few insurance companies like PSU insurance companies, pre-auth in original, and you don't need to give a covering letter. You don't need to put a letter on the top that addressed to the insurance company that kindly find the claim documents that are not required. Just take a print of the final approval document, put it as a first page. They will track it. They know their document. They understand their document. So investigation original in the sense our biometry and Aadhaar card, insurance card, final bill and discharge, and along with that KYC document. Now understand, initial consultation document is not required. HIV HbA1c report is not required. Okay. Any other document, patient has come to you with the entire bunch of policy document, 5-6 pages, not required. The first page showing the policy number is enough. Okay. If you are attaching the insurance card for the TPA, that is more than enough. You don't need to attach the policy document. Okay. Now, why I'm saying not required is because, let's not make that 10th standard pass guy, confused. वो देखेगा ये कहाँ से आ गया. So I have seen people attach ECGs. I have seen people attach X-rays. These are not required. And we don't need to put an OT notes for daycare procedures. Daycare procedures are defined as surgeries which can be done in a short span of time. There is no time for case sheets. There are no time for OT notes. Leave it. One page discharge or one page final bill. If you have upgraded the implant, then the invoice. Okay. Now, so all page and this thing. So yes. I just want to touch upon one aspect, which is, okay. Sir, would you, Puneet sir, if you don't mind, we'll take some questions and then we'll continue from there.
Yeah, we can take some question and then we can continue.
Sure.
I'll ask Dr. Ruchir. Dr. Ruchir,
Yeah, hi sir. Sir, I
yeah,
was going through all the
can you take
questions.
up some questions from the beginning because there are many questions lined up.
Right, sir.
Then we can start the talk again.
I think the first question is why should insurance company not pay immediately on giving final authorization?
That is because final authorization, see, there's a element of trust. Okay, there's an element of trust. So here, unless and until the insurance company is satisfied that the documents are correct, the treatment is correct, the patient is correct, they will not make the payment. So they need some time for verification of document. That is why you have to send the copies. Point number one. Second, when we talk about a TPA and an insurance company, the bill processing is done by the TPA, the payment is done by the insurance company. So in order for this file to move to there and there also the scrutiny to happen and come, the payment gets delayed. As of now, I can proudly say that my hospital payments, maximum delay in payments is 1 month.
1 month.
1 month. And as I'll tell you, the earliest payments would be like 72 hours, where it's a direct in-house handling. Like ICICI pays within 72 hours. Bajaj Alliance also, most of the cases, the payment is pretty 1 week. So the thing is, again, your document processing is delayed when you have ambiguity. Remove ambiguity, you'll be safer. So understand that there will be delay in payment. That is why it is called as a credit bill. Okay, it's a credit billing system. So the delay in payment is going to be there. As time goes, that delay is going to become shorter.
Right. So the next question is what is the present health insurance penetration rate and what is the claim rate in India? And I would actually add to it, do you think that the entire nation will move towards cashless in a few years' time?
Sir, the biggest health insurance penetration, if you look at it, is pretty much good. I'll tell you the thing. I spoke to one doctor in Pune, practicing in Hinjewadi, Pune. She opened her hospital 6 months back. Okay, she was working in another institute earlier, and she said she does around 25 to 26 cases in a month, which is a very good number for a single practitioner. I asked her, ma'am, how many of them are insurance cases? She's like 100%. 100% insurance cases. Now, understand, Pune, Hinjewadi, IT Park. So your 100% cases are insurance cases. Whereas if you look at some other locality, the number of cases of insurance will be very less. Rural centers, it will be very less. So it varies, the insurance penetration rate varies according to the locality and population that you're serving. That's one. Now, will the entire India go into cashless? Do you know which is the biggest cashless scheme? Ayushman Bharat. When Ayushman Bharat is cashless, what is stopping insurance companies from being cashless? So Ayushman Bharat is one of the inspirations for GIC for going cashless anywhere. Okay, so cashless is going to stay. It is going to increase over a period of time. You are going to see a lot of cashless cases happening. If you are not signing up, you will miss the train. That's my suggestion. Otherwise, you should be that kind of a practitioner, sought after, that even if you don't have cashless, you can survive. But in this current zamana, where people look at, I'll tell you, Vistara is a full service airline, Indigo is a low cost carrier, but always we will search on Indigo first. If you don't get on Indigo, then only we go to Vistara, right? That happens with the patient. We have become a commodity, sir.
Right. The next question, Dr. Anand Mohan, I think it's already been answered about IOL bills for package rates, and if we that has been answered. What is the main role of TPA? You've already touched upon that. That TPA is the
Main
process.
role of TPA is basically bill processing. Okay, So third-party administrator is for bill processing. Now, you should understand one important factor that the corporate companies are fond of their TPS because of the services they give. Now, a company like, for example, Infosys. This is just an example, not okay. Infosys, just a name. So if you take a corporate like Infosys, they have a New India Assurance insurance with MediAssist as TPA. Now they have been working with MediAssist for so long because the front contact for the corporate is the TPA. Any problem with the insurance claims, they will contact the TPA only. So their coordination with MediAssist would have been so well, so nicely established. Like even if MediAssist tomorrow says, "Sir, leave New India, we will take it from United this year," Infosys will say yes. Okay, so this is the kind of power the TPA has because of their processing. They are the end service provider as far as they are concerned. So TPA's job is to process the claims and forward the approval to the insurance company for payment. TPA doesn't do the payment. One thing that you should be very clear is that denial of a claim has to come from the insurance company, not from the TPA. ओके अगर आपने ऑपरेट करने के बाद आपका डिनाई हुआ है तो वो डिनायल आपका इंश्योरेंस कंपनी से ही आना है, टीपीए का नहीं सुनना है. Next is TPA is not supposed to collect any money from the hospital. TPA is paid 3% of the entire business amount by the insurance company as SLA. Service level agreement उनका अलग से बना होता है. We don't have to pay anything. The payment to the TPA is done by the insurance company. That is the TPA.
Right. Now there's a question. Can you elaborate on the new directive? This is about the cashless everywhere for non-network hospitals.
So cashless everywhere for non-network hospitals was very nicely explained yesterday by Mr. Anuj. I would repeat his line. Okay. So look at the cashless empanelment as a marriage, as an arranged marriage. Okay. We sit, discuss, everybody comes to an agreement that ये हमारा लेन, ये हमारा देन, ये हमारा एक शादी हो गई भाई, एक रिलेशन बन गया. We have formed a relation. Okay. Now, cashless anywhere is like dating. Okay. Now, cashless anywhere mein, there is no clear cut this thing. What to say? There is no clear cut agreement for long term. So, how does cashless anywhere work? Is I have Star Health Insurance. Now, Dr. Ruchir's hospital does not have an empanelment with Star Health Insurance, but I want to get myself operated by him. I will go to him and say, "Sir, I want to get operated by you, but I want cashless." So Dr. Ruchir will say, "No, cashless anywhere has come. So you can go ahead. This is my estimate. I will be billing you 40,000. Okay, is my charges. You want to process in cashless? Please go ahead." So I, as a patient, will contact my insurance company, the customer care or the cashless anywhere contact number. The moment I contact them, they will ask me which hospital. I said this hospital, falana, falana, falana. This is the estimate. Now, the insurance company will send a pre-auth form to me or the hospital directly, asking you to fill it. So either the insurance company sends to Dr. Shishir directly, or they give me and I give it to him. So anyway, Dr. Ruchir will end up filling a pre-authorization form. With that pre-authorization form, there will be one more document in which Dr. Ruchir will be asked to fill his hospital details also. Why? Here we are the insurance company and Dr. Ruchir's hospital is not in a relation. It is a first encounter. So this is the initial summary. So those data also he will fill and either directly or through the patient will send the pre-authorization to the insurance company. Okay. Once the pre-authorization reaches insurance company checks and says that, okay, everything is fine. The hospital is genuine. The treatment is genuine. The price is also, I don't think it is genuine. So what the insurance company guy will say, he will come back to Dr. Ruchir and say, "Sir, hum cashless de rahe hain. Ek 10% discount kar do." So he will say, "Yes." Okay. So you will discount the price to 36,000, right? Now the patient comes to you and gets operated. Now, the moment he comes to you and gets operated, before this, you and the insurance company will sign a one-page document saying that we have agreed to extend cashless for this one case. This is the amount approved. This is this thing. I undertake to take care of the patient, and the medical complications is my responsibility and whatever it is, you will sign. Insurance company will sign. That's a one-page MOU just for that case. Okay. You will operate the patient, and then you will send the approximate bill and discharge, same process as cashless, approximate bill and discharge to insurance company again. They will give a final approval and you will discharge the patient. That final approval is your authority. And when you initially sent the documents, the insurance company would have taken your PAN number, account details and everything, and they will issue the payment to you later on. Now, in these few things that we need to look at is, in the initial dialogue itself, you should clarify the payment timelines, that कितने दिन में पैसा दोगे, अगर इतने दिन में पैसा नहीं दिया तो क्या पेनल्टी दोगे, और अगर पैसा नहीं आया तो किससे बात करना है, who is the person, nodal person, and who is his boss. Escalation level 1, escalation level 2, escalation level 3. These 3 details you will take and keep it with you so that in case the money doesn't come, you can always fight. Okay. And then the patient goes happy. Within 30 days, the money comes to their account. You are also happy. This is the happy cashless anywhere situation. But there can be many other unhappinesses, which only time will tell.
As it goes on. So
as a process improves.
Okay. Do we require Rohini registration for cashless everywhere?
So it is not mandatory. It is not mandatory, but it will be easier. It will be easier to get a Rohini registration. Why? Is because Rohini database already has your data, and insurance company can cross-check with it. You are empaneled with some particular insurance company, your hospital has been getting payments, that means your data in Rohini database is correct. So this particular insurer can also go and recheck there for genuinity ki ye sahi hai ki nahi. Aapse hum kam document, the insurance company will ask less documents from you then.
Right. So you think a hospital will also get empaneled after this, or there are higher chances that
one odd case ke liye to nahi hoga. See, it's okay. The same Mr. Anuj's example again. You go for 5-6 dates, then suddenly you think that, okay, let's get married.
Right.
Okay. So that's how it goes.
Right. There's a question that sometimes they give approval in 2 parts. So what is the criteria for that? I think it's about the initial and the final approval, or you think final can also come in different parts?
It cannot come in different parts. Okay. It's a stage. I wouldn't call it parts. Initial approval and final approval are different stages. Initial approval is the first stage, final approval is the second. Now, we are ophthalmology hospitals, daycare centers. That's why I'm not talking about an intermediate. There is one enhancement also in between. But that is as far as I understand, and as far as I've been working with hospitals, there is no need of sending an enhancement for ophthalmology cases. That approximate bill that you send itself is an enhancement actually.
So approximate bill, I'm a retina surgeon. I would want to ask from my point of view. Suppose I have a package rate for say 60,000 for a VR surgery, and it says that I have to include membrane peeling and endo laser and everything. Right. So I have done that. But during the surgery, I used 2 bottles of oil. I used a PFCL. How do I bill that?
So understand, sir. See, retina is a slightly complex issue in terms of insurance. Okay. Now, when you say package rate, yesterday, see, you just told me that you operated a case today where you used 2 PFCL bottles.
Yeah.
Yesterday, you would have operated a case where you would have used 1.
Right.
Right. There would be some days there would be 2 cases and you would have used 1 for both.
That is true, but the situation.
Wait, let me complete. When you say a package rate, that is supposed to include all the routine consumables.
Fair enough.
Got it?
Yeah, fair.
But I'll tell you what. Now, if you're a VA surgeon, okay. Now, after surgery, if you put a BCL, okay, I don't know, I can't think about much. In cataract, I can tell you. In
No,
cataract, you have a package rate of 25,000 and you put a CTR.
Right.
You can bill the CTR separately.
So that will be extra consumable.
Yes.
So this will be separate from the package.
Yes. See, understand, there's a difference between consumable and implant.
Okay.
But you have to produce the bill of
Yes.
that consumable.
Okay, sir. For this let me go back to one small aspect which I missed out. Okay, so in insurance billing or any form of billing, you need to remember something called as GST, goods and services tax. Right? There is something called goods. There's something called services. Now, when I say a cataract surgery package, it's a service, and when I add a CTR along with it, it's a goods. When I make a breakup bill of surgeon fee, OT charges, these are healthcare services. Healthcare services are tax exempt, so you don't need to produce an invoice for it. But whatever is healthcare goods, you have to produce an invoice for it. That means whatever is healthcare service, a package rate is a healthcare service. Surgeon fee, healthcare service. OT charges, healthcare service. Room rent, healthcare service. Anesthesia charges, healthcare service. Surgeon, so in those you don't need to supporting evidence nahi chahiye. But if you put an IOL, it's a healthcare goods. If you put a separate item called CTR or any consumable also, you put a syringe, you put a gloves. The moment it appears separately in a bill, it's a good. So all the goods has to be supported by a tax invoice separately. Why? Because healthcare goods are taxable under our taxation laws. So that is why whenever you put a higher option implant, insurance company will always keep on asking you, invoice chahiye, implant invoice chahiye. But when it is part of a composite supply, if you give a package bill, it's a composite supply. That is, the implant becomes part of the healthcare service delivery. There it is not taxable under GST. So that is why when you bill in a package, you don't need to provide an implant invoice.
Right.
So,
and what about monofocal and multifocal IOLs? Lot of questions are there about when we are upgrading the implant, can we, if we have a package for MICS with monofocal IOL, so can we legally shift the patient to a multifocal IOL or a trifocal IOL?
yes, you can.
And
Yes. I'm just showing you, I'm showing you a template for it.
Right.
Go ahead with the next question. By the time I'll open the template.
Dr. Priya is asking now that cashless everywhere is going to prevail, is it prudent to get into empanelments?
Yes, it is prudent to get empaneled, because otherwise what is going to happen is every time you are going to have the same argument again and again, same rate negotiation again and again.
Right.
And it is going to eat your time.
The next question is, once empaneled with GIPSA, do we need to share GIPSA rate list with new insurance company that want to empanel us? Because I think we've also had this a lot of times that they say that we'll empanel you at GIPSA rates now. We won't give you anything more.
Sir, now coming back to the same thing. When you go and buy an equipment, Ruchir sir wants to buy an IOL master. Dr. Hari has bought the IOL master at 32. Now Ruchir sir will go and tell Zeiss, you gave Dr. Hari at 32, I also wanted 32. That is the same reason, sir.
Fair enough.
Okay. Now I'll tell you how I circumvented that is, I said was, if you are going to give me the same volume of GIPSA, I'll give you the same.
Right.
So I have insurance companies to whom I send the GIPSA rate, and I refuse because was GIPSA rate nahi dunga main. If you can give me 10%, 20% more than GIPSA rate, you are a private insurer, please go ahead. Sir, just a minute, I'll share my screen. for that template thing. So can everybody see this template? Okay. If you want, please take a screenshot and keep. So understand that whenever you have an agreement, your implant cost is mentioned. A monofocal implant is supposed to be costing 7,000 rupees. Some cases it is mentioned, some cases it is not mentioned. Okay. Now, in this case, I have just imagine that I have a tariff rate for monofocal lens at 28,000 rupees. I want to put a PanOptics for this patient. PanOptics, whatever is the rate for PanOptics, PanOptics, okay, MRP comes to 65,000. Okay. Now, out of that 65,000, 7,000 is included in the package. I can collect the balance amount. I can put the balance amount as a separate item. If the insurance company wants to pay the entire bill, they can pay. Otherwise, I can collect it from the patient. So, as I told you, again, that foolproofing your bills. If you go through this bill, it is very evident that we are billing according to package. Okay, we are billing according to package. However, additional charges for upgradation of implant, upper Sami region, MRP 30 minus 7,000 above, because 7,000 upper include ho gaya. The balance amount I have put, total amount is 51. And then comes the rest of the things as normal. But in this case, remember one thing, whatever rate you mentioned here, you should be able to support it with a tax invoice. Not MRP letter, not pro forma invoice, not your letterhead signature stamp, but a tax invoice. Then only this format becomes foolproof. Now, with this format, understand, with this 28,000, I can bill PanOptics only 65 MRP plus 21. If I look at, I can bill only at 86. I cannot bill at 1 lakh. Okay. Now, so this is the format in which we normally upgrade implants. So here it is very clear.
Right.
Okay. Next, sir.
Next is sometimes discount is asked for non-JIPSA cases.
Non-package cases.
Non-package cases. That I think we've already discussed that, right, from the open billing. And sometimes they give approval with discount and again cut discount at the time of payment.
That is, see, whoever has asked this question, those particular bills where this kind of a situation has happened, I would like to see those.
Right.
Because, see, there are systems which are followed. Okay. The problem with insurance companies, they don't deviate from the systems. If you send a breakup bill, then they will deduct. Now, there is few more clauses. Okay. There are few more conditions and terms and conditions that you should know. Since we are mostly cataract and package case people, I didn't want to touch upon that. But remember this, that whenever you make an open bill, surgeon fee should not exceed 30% of the full bill, total bill. OT charges should not exceed 30% of the total bill. Anesthesia fee should not exceed 25% of the surgeon fee. Okay. Room rent to not exceed 5,000. Sorry, 4,999. Why? Because 5,000 room rent is taxable by GST. You will have to give a separate invoice for it. Then the entire GST will come. So room rent not to exceed 4,999. Nursing charge is included in the room rent. There's no separate nursing charges. So whenever you put nursing charges, if you put nursing charge 2,000, room rent 4,000, insurance company is going to say that 2 plus 6, 2 plus 4, 6. Provide invoice. Okay. So that you should be clear. So these few parameters, if you maintain, these kind of situations doesn't happen. So if there is a double discount being detected, I am eager to know why.
Right. So Dr. Shweta is asking that certain companies like MD India apply a discount even on package bills. How to deal with it when they don't respond to calls or mails regarding the same?
Put an email to the grievance. Just don't, we normally get emotional and write a 1 foot long email, not required. You just need to put a line to the grievance department, claim number so and so, discount deducted in violation of agreement.
Right.
You understand the wordings? Full stop. That's it. The reason we should be very clear what we are trying to express.
Right. So one thing that again that I wanted to know was there have been instances when we have not received the final approval by day end. Now, as daycare centers don't keep the patient indefinitely.
Sir, if the final approval has not come by day end, you can collect the money from the patient.
And patients, and when the patients do not want to pay the deposit money, a lot of instances have happened.
If they want to pay, do not want to pay the deposit money, tell them, sir, we are not responsible. See, first thing, see, the problem is that we sometimes I have seen doctors talk to patients कि अरे आपका इंश्योरेंस से सब कुछ हो जाएगा सर, हम कर देंगे. नहीं, ये गलती मत करना. You are not the person who is controlling the insurance company. Insurance company is the insurance, health insurance is held by the patient. We should make that aware to the patient in the first place. Ki hospital didn't provide you this insurance company provided you the insurance. Terms and conditions, you know, I don't know. If the approval is not coming, I don't hand over the discharge document. If a patient says you cannot pay, I normally say, भाई document नहीं मिलेगा. देखो मैं पुलिस तो है नहीं कि मैं लॉक करके रखूं. You can walk out. But कौन सा लेंस डाला, क्या सर्जरी हुआ, कितना हुआ, क्या हुआ, कोई डॉक्यूमेंट आपको नहीं मिलेगा.
Right.
Patient is responsible for the payment finally, actually. Insurance company is just making the payment on behalf of the patient.
Right. There's a question by Dr. Anand Mohan. I hope in the present scenario, there are very high chances. Are there any chances of tariff revision and rate enhancement? If possible, please advise.
The only way rate enhancement is possible is when we can collectively enhance the rate. Okay.
Right.
Okay. Now for this, I will give you the example of VR surgery. Okay. Now, Ruchi sir, you would be aware that VR surgery, vitrectomy, a lot of insurance companies pays around 20,000 also for VR, right?
Yeah.
Very sad state. I totally, empathize on that part. I think you people are doing a fantastic job and you deserve much more. But what is happening is, when an anterior segment surgeon like me, I get a tariff rate from the insurance company as proposal. What they will do is, what I'll see, tariff, cataract, 24,000. Phaco 24,000, MICS 28,000. Okay. Pterygium 25,000. I only do this. I don't care about the rest. So in that list, bottom, no, there is a line. Vitrectomy, 500 rupees. I didn't see that. And I don't care to see it. And I'll sign it and send. The mistake I did is, I just lowered the average. So what happens is, the reasonable and customary cost of vitrectomy in the region has gone down. And once it goes down, सस्ता होने के बाद महंगा नहीं होता. In a credit building situation. So what we need to do is, as an anterior segment surgeons, we should show some solidarity to VR surgeons. Tariff, please look at the vitrectomy also. So if you want a tariff revision, sir, first thing you should do is that try to contact them and try negotiating. Insurance company, if they don't budge, the only way you can is make them here by using the finance. The revenue is the only thing that hurts them. So for that, what you'll have to do is, you will have to suspend cashless. You'll have to terminate cashless. See, have you seen, few fantastic people who go for shopping? They go to a shop, bargain, where sari dress kharite time. That guy will say 1,000, we will say no, 200. Okay.
Palika Bazaar.
Huh? Palika Bazaar.
Palika Bazaar, yeah.
Palika Bazaar. And Palika Bazaar में वो एक टाइम होता है जब तुम अरे रहने दो यार, इतने रेट में नहीं चाहिए करके जो मुड़ के जाके जब निकलते हो ना, तब पीछे से बुलाते हैं. बट वो पीछे से तब बुलाएगा ग्राहक दूसरा नहीं है. उसके दुकान में जब भर भर के ग्राहक होता है तब नहीं बुलाता. तो एकदम जैसे ही सर if we have, if we terminate cashless, we should be sending reimbursements. We should be actively pursuing reimbursement. So how do we send reimbursement? How to increase reimbursement is by two ways. Firstly, we make our systems, our hospital should support the patient for reimbursement. कि मतलब फॉर्म भर के देना, कौन सा फॉर्म कहाँ भेजना, उसमें we should be able to help them out. Second way is there are insurance credit companies. There are few companies which has come up who give short-term credit extending to the patient and reimbursement को pseudo cashless जैसा model चलाते हैं. You can use that companies also. That's up to you, which way you want. But unless and until you can't prove that you have enough patient outflow, देखो empanelment हो जाओगे तो 25,000 में केस करोगे, reimbursement भेजोगे तो 50,000 में भेजोगे. So that insurance company gets hurt. There's no doubt in that. So you should have that numbers. So cashless anywhere may you can start off. If you are not empaneled, cashless anywhere you start off, but they will get this thing numbers.
But there will be no patient or hardly any patient who will be ready to get reimbursement surgery done if they have the option of cashless in some other hospital. So they will not want to pay from their pocket. It's very difficult. It's very, very difficult.
So we should be doing something additional in order to, that care and the support that they receive in your hospital should be much more than what they would receive in the
So
other.
that is not given any importance. Money is the main importance. They don't have to pay anything from their pocket. That is the most important thing for many patients. They don't care about any other thing. That is my experience.
Well, आजकल over a period of time commoditization हो गया, sir. I don't deny it. I don't deny it. Doctors are, we are just another electrician, plumber, AC technician.
Right. So it's very difficult to, either everybody goes cashless, then only it is possible. One person or two people or even five people in the city going cashless makes no difference to the companies. It makes all the difference to the people who go cashless.
Got it, sir.
Sir, I'll interrupt. We have already exceeded the time. I'll ask Mr. Namneet from Micro and Dr. Vannadil also. Can we extend till the questions are finished?
I think, sir, we only have three or four or five questions, I guess.
But if these two people are ready to support us, there is no, we don't have any problem.
मुझे
from our side, no issue, sir. Navneet here.
Right.
Okay.
Yes.
I'll hurry up with the questions. So, one question is by Dr. Priya. Many a time the final approval is short of the full amount. They use vague terms without specifying the rest amount can be collected from the insured. How do you address these issues?
So when you say vague term, you should understand, the term is vague for you because you have not understood the term. Let me put that. So basically, abhi jaise, if I was a general practitioner, Ruchi sir, SOR, ELM, ILM लिखेंगे, मेरे को समझ में नहीं आएगा. So मेरे लिए वो vague term हो गया. So it's high time that we train our staff in the insurance billing systems so that they understand things better. Now, vague terms, basically you should know where to look for. The term final, the term sublimit, the term agreed package, the term RNC is reasonable and customary. Vogue, VOGUE, in vogue. Okay? And these are few terms that insurance companies standardly use. And for them, it is standard. Just that we don't understand it. So what I would say is we just need to have a dictionary to understand this part. We just need to have a translator. So that translator would be one or two of your staff whom you can train, and so that they are better off. As of now, what I would say is that one of the problems that lack at both places, insurance companies as well as hospital, is lack of skilled workforce to handle the documentation.
Right. One other question is that if you are registered with an insurance company but not with the TPA involved, so can you still process the claim? So
I will categorize this insurance company TPA conglomerate into three parts. Okay. And that too depending on whether you are in a GIPSA city or not. Okay. Now, if you are, first let's talk about for people who are in GIPSA cities. GIPSA notified cities, like as of now, Lucknow, Meerut, Delhi, Chandigarh, Hyderabad, Nagpur, Pune, these cities, if you are located, then you will be guided by the rules of GIPSA committee. Now, what are the rules of GIPSA committee is that irrespective of the TPA, the rates of the rates that you have agreed with the GIPSA committee will be applied. Okay. Now, in that same city, okay, if you are empaneled with the TPA separately, that is only for private insurers. Okay. So in a GIPSA city, for example, you are sitting in Delhi, which is a GIPSA notified city, a patient with an insurance card of United India Assurance, which is a PSU insurance company, and Health India TPA, you in spite of you not being empaneled with Health India TPA, but empaneled with GIPSA, you can do the case, you can blindly send a pre-auth to Health India TPA, they will honor it.
Right.
At the same time, in Delhi itself, you're a GIPSA city, you have a patient with an insurance card of ICICI Lombard with Health India TPA, and you are empaneled with ICICI Lombard, but not with Health India TPA, you cannot send that. You have to be empaneled with the TPA when the insurer is a private insurer. Okay. Now, if the insurance card doesn't have a TPA, only the private insurer, you need to be empaneled with the private insurer. That's no doubt. Now, let's step out of Delhi to somewhere like Himachal, Shimla, not a GIPSA city, not a GIPSA notified city. There, the rule is very simple. You have a health insurance card. The TPA you should be empaneled with to process the cases, whether of PSU or of private, doesn't matter. If the card has got a TPA name, you should be empaneled with the TPA. If the card doesn't have the TPA name, you should be empaneled with the insurance company. That is the rule for non-GIPSA places.
Right. One question is from Dr. Anshu. He's asking what to do if the final approval comes less because the limit was exhausted for a particular procedure.
Very simple. If the limit was exhausted, that's the happiest thing to happen. If the final approval mentions limit exhausted, please collect the balance amount from the patient.
Right.
Because that's a very clear-cut thing where the insurance company has clearly told you, इससे ज़्यादा हम एक पैसा नहीं देंगे.
Right. So what can we do if in the final approval insurance company mentions do not collect from the patient if we send for an upgraded package?
Okay. अभी ऐसा है, I'm giving you the situation. 50,000 surgery, initial approval 50,000, final approval came as 40,000 approved. देखो इसमें first criteria is your package is 50,000. Okay, अभी रुचि सर की बात करते हैं. VR surgery 60,000 package, right? Now you said the pre-auth was 60,000, insurance will approve 60,000. Okay. Now उसके अंदर अगर इंश्योरेंस कंपनी बोलती है not to collect from the patient, तो उनको 60,000 पूरा अप्रूव करना था. अब VR के अंदर लिमिट की कहानी आएगी नहीं. अभी सेम थिंग कैटरैक्ट के लिए, ठीक है. नाउ कैटरैक्ट में ऐसा है 50,000 का पैकेज है, आपने इनिशियल अप्रूवल भेजा, 50,000 का अप्रूवल आया इनिशियल, आपने ऑपरेट किया, फाइनल अप्रूवल भेजा, तो उसमें क्या आया, अप्रूव्ड अमाउंट 40,000, सब लिमिट एग्जॉस्टेड, डू नॉट कलेक्ट फ्रॉम पेशेंट लिख दिया है. डजंट मैटर, स्टिल इफ सब लिमिट इज एग्जॉस्टेड, प्लीज कलेक्ट फ्रॉम द पेशेंट. Only criteria is that's a mistake from the insurance company part. I said there are idiots everywhere. There are people who in the insurance company also need training. There are instances where these kind of there are times when these kind of approvals, people have sent it to me. I have sent it to the insurance company, and the staff who processed that claim got a kick because he did a mistake. उनकी गलतियों का हमको उनको बताना जरूरी होता है. तो this is a mistake. Sublimit exhausted and you are not deviating from the package. See, ये एक चीज बड़ा important है. You are not deviating from the package. Then please collect the remaining amount from the patient.
Right. So one question is, can we upgrade Ayushman cases to premium IOLs? I don't think we can do that.
I don't think so. Ayushman cases you cannot upgrade to premium packages because Ayushman case, Ayushman Bharat is a subsidized healthcare. It is not a right. So it's a very different thing. Government is paying for it. The rules are very different. I don't think so.
Right.
Does Ayushman private hospitals पे कैटरेक्ट के लिए अलाउ किया है कि नहीं?
सर वो कुछ जगह पे किया है, वो डिपेंड करता है एसएचए कौन है, एसएचए के डिसीजन के ऊपर है. तो अभी ऐसा है, अभी मैं आई विल गिव यू कंपैरिजन एंड कंट्रास्ट विद 2 गवर्नमेंट स्कीम्स, ठीक है? वन इज आयुष्मान भारत, सेकंड इज ईसीएचएस। देखो सुनने में दोनों गवर्नमेंट स्कीम लगता है, राइट? ईसीएचएस एंड आयुष्मान भारत बोथ साउंड लाइक ए गवर्नमेंट स्कीम. Ayushman Bharat is a truly government funded scheme. ECHS is not. ECHS is a contributory health scheme, जहां पे लोगों ने अपने से कंट्रीब्यूट किया है. ECHS के अंदर इम्प्लांट का कॉस्ट का लिमिट है 5,800 रुपीज. उसके ऊपर का इम्प्लांट का कॉस्ट आप पेशेंट से ले सकते हैं, बिकॉज इट्स ए कॉन्ट्रीब्यूटरी. Everybody contributed equal amount. I want better service, I'll pay the difference amount. Whereas in Ayushman Bharat, the government is putting the money, so it's not allowed. That's what I understand.
Right. So
But it's been heard that, just to interrupt, it's been heard that nowadays these Ayushman Bharat patients are willing to pay extra for a better lens and all that. So what happens in
Sir,
such a
they are
scenario?
willing. Sir, they are willing. बट उसमें से एक आध आदमी भी उठा के आपका रेसिप्ट लेके चला जाएगा ना फिर एसएचए के पास.
So it should not be encouraged. It should not be entertained. Such a person should not be entertained. उसको जो पैकेज है उसी में करना है.
Sir, I don't know whether you are aware. See, if a person has got 2 health insurances, he can claim from both. जो पहले में सप्लीमेंट एग्जॉस्टेड डिफरेंस अमाउंट उसमें पे किया वो दूसरे से क्लेम कर सकता है, मगर आयुष्मान भारत का बैलेंस नहीं क्लेम कर सकता. यू कैन नॉट कंबाइन हेल्थ इंश्योरेंस एंड आयुष्मान भारत. You cannot combine health insurance and CGHS. You cannot combine health insurance and ECHS.
Actually speaking, such a person who is able to afford health insurance should not be having a Ayushman card, no?
Point. Sir, ये मेरे पे स्केल के बाहर है सर. Next, sir.
But there are many such cases.
Yeah. So next question, I think partly it has already been answered, but if there is an MOU between the hospital and the TPA for cataract surgery is 15,000, but the patient wants panoptics implant.
I already explained. I show the template. कैसे करना है दिखा दिया है.
So the surgical charges would remain fixed and the implant cost would vary.
Yes.
Right. Perfect. Right. This is a very pertinent question, I guess. If during cataract surgery PCR happens and anterior vitrectomy is done, CTR is done, and the lens is changed, how to proceed with the TPA?
Change the diagnosis.
Okay.
So how to proceed with the TPA is that you convert it to an open case. It's totally understandable, sir. Okay. This is the rare case where you can put an enhancement also. You can put an approximate bill also. It works. So what you need to do is you make a discharge summary which mentions these aspects. Okay. It should be, the diagnosis should be cataract, number 1. Number 2, posterior capsular rupture. Number 3, okay. नहीं वो that सर्जरी में आएगा. सर्जरी में आएगा फेको emulsification, ठीक है? Then anti-vitrectomy, then SFIOL, whatever. So iris claw lens fixation. So it should be mentioned as separate surgeries. Okay, and give a proper breakup open bill. उसके अंदर MICS मत लिख देना सर. Because see the problem that happens is if in your discharge anywhere MICS cataract surgery phacoemulsification दिख गया, इंश्योरेंस कंपनी का 10th पास बंदा क्या करेगा? बोलेगा ये तो पैकेज में डालना चाहिए था.
जो pre-auth था, pre-auth was for MICS with IOL.
No worries.
When we are sending for an enhancement with open billing.
Yes.
Okay.
What about the post-operative endophthalmitis if it happens?
Sir, post-operative endophthalmitis is treated as a separate case.
In the same hospital?
Yes.
So what I have done in a few cases is phaco without IOL. We did not charge for the IOL, wrote anterior vitrectomy hospital charges. And then after 3 days did vitrectomy and SFIL and then a separate procedure, and most of the time it works.
Yes, that works. That also works. In the same sitting also you can, sir. See, you put it as diagnosis, put a diagnosis that posterior capsular rupture with aphakia and mention the vitrectomy and everything and close.
Right.
Sir, it is very, see, the thing is, there are cases where a patient has been opened up for appendicectomy and came out with a salpingectomy. Right? So these kind of things, they also understand. See, understand one thing, sir. Every insurance company, claim processing team has got doctors on board. Just that they don't handle every case. Escalated cases, they will handle. So the 10th standard fail guy should not put his mind and directly take the case to doctor, the claim will get passed. So don't put MICS in this.
Right.
In case one has taken authorization for say MICS, and you get, in that case, you don't always get a initial authorization and final authorization. That doesn't happen all the time. It only happens sometimes when you have a initial and final. So in case, supposing you've got one authorization which you are authorized to do MICS, and then you happen to have this rent. So then do you request for a final authorization? Then what do you do?
We put for a final approval.
Then you request for it, because it's not being given to you.
Sir, always, sir. You have to always ask for a final approval.
I see.
They never stop at initial approval. Final approval is a document. Initial approval is not a document. Initial approval is like, हाँ तू कर ले. तू कर ले.
No, but they don't always give you an initial approval. Sometimes they give you just approval. It's not initial or final, like it's approved.
Sir, सर्जरी से पहले वाला अप्रूवल इज इनिशियल अप्रूवल, सर्जरी के बाद डिस्चार्ज वाला अप्रूवल इज फाइनल अप्रूवल. उसके ऊपर हेडिंग कुछ भी लिखे.
So that is in all cases, in all companies, in all TPAs, it works like that.
Yes, and yes.
Okay.
Sir, hello.
Just Dr. Girish Kane from Oracle Eye Hospital wants to ask something. He's looking after the practice management cell in UPSOS. So please, Girish, doctor, please ask the question.
या डॉक्टर हरी, आपकी टॉक बहुत अच्छी थी, बहुत सारी चीज़ें आपसे सीखने को मिली. मेरा कुछ चीज़ों पे क्वेरी है. जैसे बहुत सारे मेरे ऐसे केस हैं मेडियासिस के कि हमने टोरिक लेंस के लिए उनको किया और उन्होंने इनिशियल अप्रूवल दे दिया, और उसके बाद फिर फाइनल अप्रूवल में उन्होंने फाइनल अप्रूवल भी दे दिया, लेकिन पेमेंट के टाइम पे उन्होंने बोला कि आपने एग्रीड पैकेज में क्यों नहीं किया, और अभी भी वो सारे केस पेंडिंग हैं.
ये बताइए सर, आपने जो देखिए आपका जो एग्रीमेंट है, अभी मैंने आपको एक टेम्पलेट दिखाया था ना,
एग्री,
जिसके अंदर लेंस अपग्रेड करने का
जी,
जहां पे आपने पैकेज से डिविएट भी नहीं किया बट आपने अपग्रेड भी कर दिया
सर. उसके बाद जब हमने उनसे आर्ग्यू किया तो
ऐसे भेजा था कि आपने ओपन बिलिंग भेज दिया था?
नहीं, ओपन बिलिंग नहीं भेजा था सर, स्पेसिफाई पैकेज करके भेजा था, जैसा आपने दिखाया ना. सिमिलरली ऑलमोस्ट उसी तरीके से किया था हमने. उसमें जीएसटी इनवॉइस भी दिया था उनको टोरिक लेंस का. अच्छा, इसके बाद हमारा स्टार से था. स्टार में क्या हुआ कि उन्होंने कई केसेस में हमें फ्री पैकेज में अप्रूवल दिया और कई केसेस में पैकेज में अप्रूवल दिया. कई केसेस में उन्होंने 27,000 की जगह 26,999 का अप्रूवल दिया, ₹1 कट कर दिया. और उस पर उन्होंने हमारा 15% डिस्काउंट किया. उसके बाद जब हमने उनसे आर्ग्यू किया, सारे मेल किए, ग्रीवेंस में लिखा, तो उन्होंने हमसे कहा कि नहीं, आपको एग्रीड पैकेज में करना है और इसी तरीके से होगा, अदरवाइज वी विल डीपैनल यू.
तो आपने उसको ब्रेकअप बिल भेजा था क्या?
नहीं, पैकेज में था तो वी डिडंट सेंड ब्रेकअप बिल.
सर
मेरा आपसे सिर्फ एक क्वेश्चन है कि हम जब इंश्योरेंस कंपनी से आर्ग्यू करने जाते हैं, उनसे बहुत सारी चीजें बोलते हैं कि नहीं, आपने ये गलत किया, आपको ऐसा करना था, हमारे एमओयू में ये लिखा था, हमारे एमओयू में वो लिखा था. तो वो सीधा सीधा हमें मेल भेजते हैं कि आपको एग्रीड पैकेज में करना है, उससे बियॉन्ड नहीं जाना है, और उसके बाद आप करते हैं तो हम आपको डीपैनल कर देंगे. और फिर उसके बाद वो हमको एक मेल भेजते हैं और उसमें ये लिखते हैं कि यदि आप इन चीज़ों में एग्री हैं तो एक आप लेटर पैड पे कंसेंट लिख के भेजिए कि आप एग्री हैं, अदरवाइज वी विल डी इम्पैनल टू यू. HITPA में हमने एक केस किया, पहले ही उनसे कंसेंट लिया, प्री अप्रूवल लिया, पैनोप्टिक डाला, फाइनल अप्रूवल आया, पैनोप्टिक का आया. फाइनल अप्रूवल उन्होंने दे दिया 82,000 का, लेकिन पेमेंट के टाइम पे उन्होंने डिनाई कर दिया. और फिर उसके बाद बोला कि आप हमें लेटर पैड पे लिख के दीजिए कि इसके बाद आप कोई भी पैकेज करेंगे वो पैकेज में करेंगे, कोई भी केस करेंगे तो पैकेज में करेंगे, अदरवाइज वी डी इम्पैनल टू यू. फिर हमें लिख के देना पड़ेगा. सर मेरा आपको एक चीज पूछना है सर, जब इस तरह की चीजें आ रही हैं तो इसको हम कैसे ओवरकम कर सकते हैं?
सर इसको ओवरकम करने के लिए ऐसा है सर, मैं अभी मैं क्या करता हूँ सर, जब तक मैं डॉक्यूमेंट आपका ना देख लूँ ना,
जी
तब तक मेरे को बताना मुश्किल है, क्योंकि सर मैं एक नहीं बहुत सारे हॉस्पिटल के साथ ऐसे डील करता हूँ, तो
जी
जिसमें हमको ये जो आप प्रोसेस बता रहे हैं वो प्रोसेस बहुत अच्छे से स्मूथली चल भी रहा है।
हम्म।
तो कहीं ना कहीं कुछ तो एक एक छोटा सा एक मतलब क्या बोलते हैं कांटा फंसा हुआ है, जो कि मतलब सिस्टम का इश्यू है, क्या है, एक बार मैं देख के डिटेल में बता सकता हूँ।
ओके सर।
उसके लिए
मैं
सर एकदम प्यार से बैठ के आपका जो भी ऐसे वाले केसेस है, आप उसके डॉक्यूमेंट अगर भेजेंगे तो मैं आराम से बैठ के उसमें देख के आपको बता सकता हूँ सर।
राइट सर, आई विल शेयर यू इन पर्सनल मेल आईडी
नो प्रॉब्लम
एंड थैंक यू फॉर गिविंग योर टाइम। और बहुत ही अच्छा सेशन रहा आपका, बहुत ही इंफॉर्मेटिव रहा।
सर।
और हम थैंक्स करेंगे डॉक्टर पुनीत का और डॉक्टर शशांक का कि आपको लेके आए। और डेफिनेटली बहुत अच्छा रहा सेशन।
सर इसमें इसमें मैं अपनी थोड़ी मार्केटिंग कर लूँ सर।
हाँ हाँ
बिल्कुल
बिल्कुल।
सर ऐसा है कि हमने एक छोटी सी किताब लिखी है, आई थिंक रुचि सर के पास है।
हाँ
नहीं, आपने
सर, वो
मुझे
अमेजन पे
ऑक्टेल वाली
अवेलेबल नहीं है,
कॉन्फ्रेंस में भी बताया था।
वो अवेलेबल नहीं है सर अमेजन पर।
वो पेशेंट्स
है अवेलेबल है सर।
हाँ
मैंने
नहीं
लास्ट देखा था सर, बट
सर, वी हैड लुक्ड फॉर इट बट हमें मिली नहीं एक्चुअली।
मैं आपको लिंक भेजता हूँ उसका डायरेक्ट।
लिंक भेजिएगा।
बस
डॉक्टर हरी, हम लास्ट
कर रहे
ऑक्टेल
थे।
कॉन्फ्रेंस में मिले थे आपसे, आपने बताया था, और वो अमेजोन पे है, मेरे पास भी उसकी लिंक है।
हाँ सर।
राइट।
तो दैट इज
सर
अ
उसको लिंक
पेशेंट
भेजिएगा।
काउंसलिंग बुक। दैट्स अ पेशेंट काउंसलिंग बुक्स, इट्स नॉट
वो
फॉर डॉक्टर।
पेशेंट काउंसलिंग है, राइट राइट।
बेसिकली क्या है कि आप अपने वेटिंग रूम में 2-3 कॉपी रख लोगे तो क्या होगा, आपका पेशेंट जो है पहले से पढ़ लेगा
यस।
कि वो क्लियरली बोलता है कि भाई इंश्योरेंस आपका है, हॉस्पिटल का नहीं। इट्स अ 30 पेजेस बुक इन द फॉर्म ऑफ अ स्टोरी बुक।
What is the name of the book?
इट्स यू मी एंड योर हेल्थ इंश्योरेंस।
हाँ ओके, तो देख ढूंढते हैं, अमेजोन में इस नाम से मिलेगा।
आपको लिंक भेज देंगे सर।
हाँ प्लीज।
आप एक बार चैट बॉक्स में शेयर कर दीजिए, जैसे पुनीत सर सारे ग्रुप में
हाँ,
शेयर।
नहीं, I'll ask Dr. Krishnan and
Send
I'll
it in the
send
group.
the
Yeah.
group. Yeah, yeah.
राइट, आई
So,
थिंक we just
Dr.
had
Ruchi, is there any more question?
रुचि सर और कोई क्वेश्चन तो बता दीजिए।
एक क्वेश्चन है सर, देयर आर अ फ्यू डे केयर प्रोसीजर्स व्हिच आर न्यूली इंट्रोड्यूस्ड व्हिच इज नॉट देयर इन द प्रीवियस एग्रीमेंट, जो कि अपडेट नहीं हुआ है। हाउ डू वी गो अबाउट दोस?
सर जो प्रोसीजर आपके एग्रीड लिस्ट में नहीं है,
दैट इज ऑल ओपन बिलिंग।
दैट्स ऑल ओपन बिलिंग।
फेयर एनफ।
सी ऑफ्थाल्मोलॉजी का हर प्रोसीजर डे केयर है, ये इंश्योरेंस वालों को भी पता है,
राइट
तो उसमें टेंशन नहीं है सर।
राइट। There's one last question. If a patient has cataract and glaucoma both, what is advisable? Do a combined surgery or do separate procedures? I think
सर लेट्स कीप द अपना क्या बोलते हैं, द 10th स्टैंडर्ड पास क्लेम हैंडलर एट पीस। ठीक है सर। अच्छा ये तो देखो, मैं आपको पूरा डिस्क्रिप्शन दे सकता हूँ कि उसको कैसे बिलिंग करना है, मगर वैसे बिलिंग करोगे चल भी जाएगा, ऐसा नहीं कि नहीं होगा। आप कंबाइन कर भी सकते हैं, कंबाइन बिलिंग कर भी सकते हैं, ठीक है। बट आई थिंक मोस्ट ऑफ द प्लेसेस, मोस्ट ऑफ द हॉस्पिटल्स ट्रैप का कॉस्टिंग बहुत कम है, 8-9 हजार 12 हजार में ट्रैप है, देन सेपरेट कर लो सर। आई वुड सजेस्ट यू सेपरेट, रीजन बीइंग इट्स एडमिनिस्ट्रेटिवली इजियर, medically clinically you are to decide।
How much gap we can means keep between two surgeries? For example, if we are combining cataract and glaucoma,
सर वो तो आपके ऊपर है
means 1 day, 2 days, 3 days, 4 days, a week, or
सर,
a month.
दोनों अलग अलग डेट पे होना चाहिए, बस
Right.
आपकी मर्जी।
I think most of the questions have been answered. So it was a great session. Dr. Shashank, please, sir.
First, I express my sincere gratitude to Dr. Major Harikrishnan Vannadil for your participation as guest speaker at our UPSOS TPA Process Improvement Initiative Group, UP. Your presentation was informative, engaging, and thought-provoking. It was clear that you put a lot of thought and preparation into your talk, and it showed. Thank you, sir.
थैंक यू सर, थैंक यू फॉर गिविंग मी
Thank you, Dr. Vannadil.
And
Dr. Hari,
I
Dr. Hari,
सर
thank
सर एक
Yes.
मिनट
sir.
एक क्वेश्चन, एक चैट में एक क्वेश्चन है जिसका मैं आंसर पक्का देना चाहूंगा। टू एम्पैनल विद इंश्योरेंस कंपनी डॉक्टर हैज टू पे सम मनी, ठीक है सर।
Yeah.
बिल्कुल जीरो.
They ask
Sir,
up to
पूछे,
1
sir,
lakh.
no, that is bribe.
Yeah,
So, सर बिना पैसे दिए एम्पायरमेंट हो जाता है. हम पैसे देंगे, हम उनकी आदत खराब कर रहे हैं.
Dr. Hari,
Sir.
There is one I think question left. Just one question left. मुझे फिर बोला गया उसको पूछने के लिए. I'll just read the question. This is, there are few daycare procedures which is newly introduced 2 to 3 years back, which is not in the agreed list between the hospital and the patient needs to undergo the same, for which the insurance company and the TPA has previously given approval for the same procedure for some other patient and denying for the other patient for same procedure, saying it cannot be done under OPD.
Sir, देखो, you should understand the difference between OPD and daycare. ठीक है सर, मैं 5 मिनट और लेने वाला हूँ. ठीक है. वोट ऑफ थैंक्स के बाद 5 मिनट लेने के लिए मैं सर परमिशन तो बिल्कुल लेना पड़ेगा. सर, few things that you should understand is there is something called as an OPD procedure and there is something called daycare procedure. सुनने में दोनों एक लगता है, but इन दोनों का definition clear है. OPD procedures are those which has always been done under OPD procedure without requiring admission. ठीक है. Daycare procedures are those which, due to the advancement of technology, are being conducted with admission duration less than 24 hours. Is daycare procedure. मतलब daycare procedure में आपका anesthesia का component आएगा, ऑपरेशन थिएटर का कंपोनेंट आएगा, पेशेंट को थोड़ा सा तो नर्सिंग केयर की जरूरत पड़ेगी, मगर ये सब 24 घंटे में खत्म हो जाता है क्योंकि टेक्नोलॉजी बढ़ गया है. सो ग्लोकोमा सर्जरी इज डे केयर, कैटरेक्ट सर्जरी इज डे केयर, वीआर इज डे केयर, स्क्विड एवरी ऑप्थाल सर्जरी इज डे केयर. व्हाट इज नॉट डे केयर इज रेटिनल लेजर इज नॉट डे केयर.
YAG laser.
YAG laser is not day care. Please, if any patient comes and asks you for cashless for YAG laser, cashless for PRP, please deny. Tell them your OPD procedure, these are not day care procedures. Okay, OCT scan cashless होगा क्या? नहीं. Investigation है भाई प्रभु, OPD कराओ, बिल लो, क्लेम करो. ठीक है. Now इसमें एक और मैं additional डाल रहा हूँ. Whenever you say day care, it is an IP, inpatient. So you apply for a pre-auth, you get an approval, and then this is an elective procedure, planned surgery. So approval आने के बाद ही तुम पेशेंट को एडमिट कर रहे हो. तो मतलब तुम्हारा टाइम ऑफ एडमिशन से लेके टाइम ऑफ डिस्चार्ज तक आप जो करोगे वो कैशलेस है. उससे पहले जो किया और उसके बाद में जो किया वो कैशलेस में नहीं है. बहुत से लोग क्या करते हैं, ए स्कैन बायोमेट्रिक का चार्ज नहीं करते. मैं तो कहता हूं चार्ज करो, पेशेंट को बिल दो, बोलो प्री हॉस्पिटल से क्लेम कर लेगा. पोस्ट ऑपरेटिव कंसल्टेशन चार्ज करो, पोस्ट हॉस्पिटल से क्लेम कर लेगा. कुछ लोग बोलेंगे नहीं ये जो ए स्कैन है ये भी तो कैशलेस में इंक्लूड होना चाहिए, उसमें लिखा है ऑल इन्वेस्टिगेशन. भाई ऑल इन्वेस्टिगेशंस फ्रॉम द टाइम ऑफ एडमिशन टू टाइम ऑफ डिस्चार्ज. जब पेशेंट का ए स्कैन हो रहा है तो प्री ऑथ भेजने वाले हो, तब तो एडमिशन हुआ थोड़ी ना है. ठीक है. तो
I'll just ask one question. Some insurance companies are asking for cashless OPD services also.
Sir, that is different. That is OPD cashless is not by the core insurance company. That are wellness companies. That's a very big topic altogether. Cashless OPD insurance company directly नहीं मांगेगी, किसी wellness company के through मांगेगी. उसको आप मना कर सकते.
Now, very good session, and thanks again to Dr. Vannadil, and because of Dr. Puneet Gupta जिनका बहुत ही इसमें effort रहा है, who put his full effort to arrange this successful meeting, and he with his core committee group working on TPA from last 6 months, Dr. Roop, Dr. Hansraj, Dr. Sudhir, Dr. Gaurav, Dr. Ruchir, Dr. Ankit are our core committee members. Thanks to all of you for your untiring effort. And I am very grateful to UPSOS President Dr. Vinod Rai and Secretary Dr. Mohita Sharma for giving the platform of UPSOS to raise the TPA issue and to fight for our right for the benefit of our members. And I pay sincere thanks to Microlab for the organizing this wonderful webinar and providing us recent information on TPA. And last but not the least, thanks to all members for giving their time and for the patience listening. Thank you. Thank you.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you so much, sir. It was great, but I think we'll have to organize such more sessions because questions are still unanswered.
It was an initiation.
This is just the beginning.
Sir, I'll tell you, if I start with my PowerPoint,
Hari,
I have, it will be 4 hours.
Dr. Hari, Dr. Hari,
Sir,
मैं ये कह रहा था कि इसमें 2 बातें जो साफ समझ में आ रही है। एक तो यूनिटी बहुत जरूरी है, जो जिस शहर में रहा है वहाँ पे अपने रेट्स वगैरह जो है वो करीब सिमिलर रखना चाहिए, उसमें बहुत कम और उसका डिफरेंस नहीं होना चाहिए, यूनिटी बनी रहनी चाहिए जितने भी जो जहाँ भी है। और अगर आप ये बताइए, जैसे हम लोग यूपीएसएस एज मतलब हम उसमें प्रेसिडेंट है, सेक्रेटरी है, ये सब हम लोग रोल इन लोगों पर दबाव बनाने के लिए कैसे हो सकता है कि हम लोग को परेशान ना करें डॉक्टर्स को? आपको कोई सुझाव है क्या?
सर वो सुझाव है, वो आराम से कभी बैठ के बात करेंगे उसके बारे में।
मतलब उसमें जिसमें कि हम लोग
बात है सर, I have a very big thought that हमारा जो associations हैं, we are more focused on academics, whereas association academics नहीं होता है essence में।
हाँ, ये हमारे एकेडमिक्स के हट के लिए है, इसीलिए कह रहा हूँ मैं कि हम लोग किस तरह से इसमें दबाव बनाए ताकि ये लोग जो बीच में जो बदमाशी कर रहे हैं, कि मैनेजमेंट कर ले रहे हैं, ये ना कर पाए। वो हैरेसमेंट भी है ना सर, हैरेसमेंट।
मैं पब्लिकली नहीं बोलूंगा तो डिफॉर्मेशन का केस हो जाएगा सर, छोड़ दीजिए। कभी आराम से आएंगे। आप कहाँ
आप पुनीत को बता दीजिएगा, बताइए, पुनीत को बता दीजिएगा ताकि हम लोग उस लाइन में चल सकें। बेसिकली मैं पूछ भी इसीलिए रहा हूँ, हम लोग का मंशा यही है कि सभी डॉक्टर्स ऑप्थेल्मोलॉजिस्ट इसकी एक छाता होना चाहिए अपनी एसोसिएशन का, कि हम लोग सब लोग बचे रहें और कंपनीज हम लोग ऊपर ज्यादा दबाव ना बनाए। ठीक है ना? तो डॉक्टर पुनीत को बताइएगा।
श्योर, मैं कम्युनिकेट करूंगा सर।
बिल्कुल, ताकि हम लोग उसी रास्ते पे चले जो आपको गाइड करेंगे। ठीक है ना?
यस सर।
सर बाकी बहुत सारी चीजें, मेरा एक यूट्यूब चैनल है आइरिस मेडिवर्स करके, तो उसका भी लिंक मैं पुनीत सर पे दूंगा, उसमें भी बहुत सारी चीजें कवर्ड हैं पहले।
यस सर।
नहीं, ठीक है सर, ओके।
हम लोग एसोसिएशन वाला मेन है कि हम लोग चाहते हैं कि सभी लोग उससे कवर हो जाए, छतरी सबके ऊपर रहे, तो वो एक इम्पोर्टेंट इशू है जो हम लोग को आप गाइड करिए। ठीक है ना? और जो एक चीज और बता रहे थे आप, एग्जाइमर लेजर वाला, कि -7.5 था और बाद में -6 जो है वो एग्जामिनर मशीन से पता किया, उसमें क्या वो उसको डिनाई कर देते हैं क्या? उसको चार्जेस नहीं देते हैं?
डिनाई करते हैं सर,
वो चार्जेस नहीं देंगे अगर -7.5 आ गया।
ये सर ये बहुत
डिफरेंट पेशेंट मान लेते हैं क्या?
सर
ये पेशेंट ठीक होना चाहिए
सर, ये बहुत लंबा डिस्कशन है। ठीक है, कभी एक दिन पूरी दिन बैठ के बात करेंगे सर।
Sure, I think now we should close it.
Definitely. Thank you very much.
Time, sir.
Okay. Thank you very much.
Thank you everybody.
बहुत ही अच्छा रहा।
Thank you. Excellent.
बहुत बढ़िया रहा।
Thank you very much.
Excellent.
Thank you, sir. Thank you, Dr. Vinod Rai, sir, for giving
Thank you,
this
sir.
talk.
Thank you, sir.
Dr. Shashank, everybody. Thank you, sir.
Good night, everybody.
Thank you,
Good night, sir,
for organizing this. Thank you.
Thank you, sir. I'll end the meeting now. Thank you.
Yes.
Okay.